Dear audience, I'm happy to present you my PhD thesis, The Role of Regional Anesthetic Techniques in Enhancing Recovery After Cardiac Surgery. My name is Tünde Szalay-Frank. I'm working as a specialist at the Department of Anesthesiology and Intensive Care at the Hospital of the Hungarian Defense Forces. My vision is that regional anesthetic techniques become part of enhanced recovery guideline in cardiac surgery, and my mission is to take an active part in forming this guideline as a researcher and a clinician as well. In order to achieve my goals, we started two projects last fall, both of them investigating the safety, efficacy, and other possible effects of additional thoracic fascial plane blocks in the cardiac surgical patient population. My first project is titled Investigating the Safety and Efficacy of Additional Thoracic Fascial Plane Blocks in Patients Undergoing Cardiac Surgery. Out of 100,000 people, more than 120 undergoes cardiac surgery yearly. Though the perioperative mortality is low, up to a third of these patients can experience some kind of an adverse event, and pain is one of the most common of these adverse events. We know that adequate pain management has a pivotal role in enhancing recovery, and we also know that cardiac surgical procedures are very painful, also the minimally invasive surgical approaches, and we also know that the cardiac analgesia is traditionally opiate-based. Additional fascial plane blocks are already part of enhanced recovery protocols for other types of surgeries, but their effect in cardiac analgesia remains uncertain. As you can see on the picture, there are several types of these plane blocks which can be performed at the thorax. They can be chosen according to the site of the surgical incision. We can administer the local anesthetic in two ways, by a single shot injection or by a placement of a catheter. Both of these procedures are done by ultrasound guidance, so thanks to that, the rate of adverse events are pretty low. Our aim is to investigate the efficacy and safety of additional TPBs in anesthesia for cardiac surgery. Our clinical question is the following: do additional thoracic fascial plane blocks enhance recovery after cardiac surgery compared to conventional analgesia? We are using the PICO framework. We are investigating a patient population undergoing any type of cardiac surgery. Our intervention is adding TPBs to conventional analgesia. Our comparator is the conventional analgesia. Our primary outcome will be postoperative complications such as pain, bleeding, surgical site infection, prolonged extubation time, or prolonged length of ICU or hospital stay. Our secondary outcomes will be opiate consumption and time to mobilization. Our hypothesis is that thoracic fascial plane blocks enhance recovery after cardiac surgery. We are implying that with the regular usage of these blocks, we can speed up the recovery of these patients, and we can reduce the costs and efforts of these patients and of the healthcare system as well. Here you can see our systematic search key, which was conducted, the search was conducted in 3 databases. We were using 2 domains, first one referring to the patient population, and the second one referring to the intervention. As you can see, we had over 14,000 results at first. After the duplicate removal, we had more than 10,000. And now, after the title, abstract, and full text selection, we have 79 eligible articles. Here you can see our progress. Right now, we are in the data extraction phase, which is planned to be finished soon. Let's move on to my second project, which is titled Investigating the Effect of Additional Thoracic Fascial Plane Blocks on the Respiratory Function Parameters in Patients Undergoing Cardiac Surgery, which is planned to be a randomized controlled trial. Respiratory complications are the leading cause of perioperative morbidity and mortality after cardiac surgery, with a reported incidence around 10%. The etiology is multifactorial, but postoperative pain seems to be one of the main causes. We know that the majority of the cardiac surgical patients experience moderate or severe pain after the surgery. And at the picture, you can see it's taken from a study performed in 2009. They were investigating the connection between the respiratory function and the postoperative pain. And you can see at the first postoperative day where the pain is most severe, the respiratory function is impaired. But after when the pain decreases, the respiratory function is improving. Based on my first project, thoracic plain blocks can be safe and effective tools for postoperative pain management, but their effect on respiratory parameters has not yet been studied. So our aim is to design a randomized control study to investigate the possible effects of TPBs on respiratory function parameters in cardiac surgical patients. Our clinical question sounds the following: do additional TPBs have a beneficial effect on respiratory function compared to general analgesia in patients undergoing cardiac surgery? We are using here the PICO framework as well. We are investigating patients undergoing elective cardiac surgical procedures. Our intervention is the same as in the first project, adding TPBs to the conventional analgesia. Our comparator is conventional analgesia. Our primary outcome will be the FEV1-FVC ratio at the 12th postoperative hour, and our secondary outcomes will be the change in other respiratory parameters and adverse events. Our hypothesis is that the impairment of respiratory function is lower with additional thoracic fascial plain blocks compared to conventional analgesia. And our clinical implication is the same as in the first project, then we would like to speed up the recovery of these patients. Here you can see our inclusion and exclusion criteria. We are aiming adult patients going through elective cardiac surgical procedures, any type of that. And we will exclude any patients who are allergic to the drugs we are planning to use. We are planning to use bupivacaine as a local anesthetic, and we are excluding also those patients who are not able to cooperate with spirometry. It's important to mention that our primary outcome, the FEV1-FVC ratio, will be measured at the 12th postoperative hour, because elective cardiac surgical patients are usually extubated within the first 6 postoperative hours, so they will be able to cooperate with spirometry by then, and the effect of these TPBs lasts around 12 to 16 hours. In summary, we are planning to submit our first project by the fall this year and the second project by the spring next year. I would like to close my presentation with a quote from Franz Kafka: "Pets are made by walking." Thank you for your kind attention.
In your second study, when you're doing the RCT, you mentioned that you're using bupivacaine. What is the dose of the medication, and do you plan a single shot administration, or is it continuous with a catheter?
Thank you for the question. It's the second project, which is very preliminary, but we discussed and we are planning a single shot injection, and we are planning to perform it before the beginning of the surgery, so we can this way we can investigate the opiate consumption during so we can also investigate the opiate consumption during the surgical procedure. These blocks are volume blocks, which means that it's not the exact amount of the local anesthetic administered, it's what really matters, but it's the volume of these blocks. So there is not a fixed dose. We should adjust them to the site where we are performing these blocks and to the size or weight of the patients.
Regarding the first project that you mentioned in the postoperative complication, I was just wondering how SSI will be related to this, the surgical site infection.
Yes, thank you for the question. Yeah, it's not, I mean, these blocks, especially when median sternotomy or a thoracotomy is made, these blocks happen to be performed very close to the surgical incision. So that's why we would like to see whether they are a risk for developing a surgical site infection.
Sorry, I was thinking about because of the breast surgery, we use PECs. Anesthesiologists are performing the PECs for us, and I was just thinking because it's a different site, and I thought maybe the incision is not the same site. So, but
yeah,
now
it's not every time, but some of the blocks are performed quite close to the surgical incision, so that's why.
So it can be a different subgroup then, right?
Yeah, we are planning to do several subgroups.
I would like to ask that, would you, or do you plan to differentiate between the nerve blocks? Because, for instance, the paravertebral block is a much more dense anesthetic block, like a peripheral one. So, are you planning to investigate a subgroup in this aspect?
Yes, thank you for the questions. As you saw, we have several articles included, and we have the opportunity to do several subgroups. So we are planning to do subgroups by the single shot or placement of a catheter, by the site where these blocks are performed, and also the type of the operation, the type of the incision. So we will have plenty, I hope.
Thank you. And would you like to use dexamethasone or something like to extend the duration of the block?
In our second study?
Yes, in the second study, sorry.
Yes, definitely. But the exact protocol is not yet drafted, so that will be. We will do it later.
In terms of the pain intensity, so do you think the median sternotomy or the lateral thoracotomy are comparable?
The intensity of pain?
Yeah, in the postoperative pain.
Yeah, we not. I mean, we just pulled the half of the data. I mean, we don't have the whole set of data, so I don't have an exact answer for that. But according to my personal experience, after the, I mean, in the first postoperative day, the thoracotomies can be even more painful. I mean, the patients are experiencing a higher or more severe pain, and we. In my department, we try to perform blocks for these patients to be a bit more comfortable, but we don't really have, I mean, right now I don't have a definite answer for that, but later on I hope I will.
To my opinion, it definitely means two subgroups for your analysis.
Yes.
And in terms of the intraoperative management, so the general anesthesia, so how could you homogenize the patients according to the applied anesthetic techniques in terms of the combined, so inhalation anesthetics and intravenous one, or total intravenous anesthetics? So what have you found in the literature?
Thank you. They are. That's a very heterogeneous. I mean, they are not using the same technique everywhere. So we also found studies where they perform epidural analgesia, which I have never seen in Hungary, but they perform it for cardiac surgery. So we have a group for that as well, and they are using it like the conventional analgesia. But usually all of the articles detail the drugs they are using during the anesthesia. So we will look into it, and we will try to homogenize the patient population, and we will try to do subgroups if possible.